My guest today on the Essential Coaching Skills podcast is Bruce Teal. Bruce is a therapist from upstate New York, a licensed social worker who incorporates NLP skills into his traditional therapy practice. He's also the former clinical director of the Research and Recognition Project, a project that used NLP skills to incredibly speed up the recovery of veterans from Ptsd. You want to hear this. You are listening to the Essential Coaching Skills podcast, a show devoted to uncovering the systems and the secrets that set the best apart, where you learn how to take your coaching clients to the next level, while you grow the coaching practice of your dreams. So sit back and relax, or sit up and get excited. Either way, you might want to pay attention. This could be important. All right. Well, I am here today with Bruce Teal, who is a New York State licensed clinical social worker, former director of the Research and Recognition Project, which I was also part of at one point, and I am thrilled to have him here. Bruce not only does a lot of work with clients in his social work practice, but he uses NLP a lot in it. So I'm really curious. I want to find out how specifically he merges these two fields. So Bruce, without any further ado, welcome. Thank you for being here.
Thank you, Doug. It is a pleasure to be here. I'm very excited and a little daunted by the level of the guests you've had before me. So I hope this isn't a horrifying disappointment for all those involved.
Well, I'd stop short of horrifying disappointment.
Okay.
You're right up there, my friend. So I'm really pleased to have you here. So, a lot of people who listen to this broadcast are people who are interested in becoming coaches, people who have perhaps just started being coaches and want to, take their practice to the next level, whatever that means for them particularly, whether it's becoming a better actual coach or therapist or being, more successful in that so that they can make a living doing that. You do both those things. That's why I wanted to have you on this, because you are well trained in both NLP and, of course, other forms of, people helping. You're a licensed clinical social worker, and you've got a thriving practice. You work more than anybody I know, which is saying
I am greedy.
Yeah, and you've got a wicked sense of humor too.
Well, I do what I can, Doug.
And I also enjoyed a really great TED Talk. I thought it was really great TED Talk that you did on how NLP does that, how you can change like phobias and traumas using NLP. And that was part of the Research Recognition Project's goal, is to show how NLP really does work for traumas. So
Absolutely.
Why don't we start there? Why don't we start with that Research and Recognition Project, what that was all about and how you were part of that as the clinical director?
Sure. So the Research and Recognition Project originally actually was the NLP Research and Recognition Project. I think just for clarity, they shortened the name a little bit. And they had been around for a little while, and then they started to focus on the PTSD/phobia treatment developed back in the early 80s in NLP. And this gentleman, Dr. Frank Burke from Corning, New York, kind of jumped on board and gave it a lot more energy than it had. And he was particularly interested in the trauma piece. He was one of the psychologists who had gone down to New York after 9/11 and just to help out. And after being down there and doing the NLP process with hundreds of people, he also noticed that there were a lot of really well-meaning psychologists, social workers, other disciplines down there that wanted to help, but didn't really have any specific tools for that. So that became his mission, was to get the word out on NLP and the trauma treatment, what they have since called the reconsolidation of traumatic memories, or RTM process, which also has been known as the movie theater process, the fast phobia cure, visual / kinesthetic dissociation. It had a lot of different names.
So that's
it's
all the
basically
same process with different names.
Exactly. I mean, there's a few variations, but overall it's the same
Okay.
thing. So actually, I had gotten a letter from the Research and Recognition Project because I had, I guess it was through email. I was on their email list asking for professionals that use the process regularly to just kind of give them a letter of confirmation that they used it, right? Kind of a little, to give them a little gravitas when they were looking for grants and so forth. So I put together a quick letter and sent it down to Frank, and the next thing I know, I've got a phone call from Frank Burke saying, hey, we should get together. So Corning and Rochester, where I'm from, are not very far away, so we got together for lunch and talked about it. And at that point in time, I was clinical director of Noise Mental Health Services south of Rochester. I had been for quite a few years. I had left that position and just did private practice. But I had an unusual triad of things that were helpful. I was a licensed mental health practitioner. I had experience with NLP, and I had been an administrator. So I started working with Frank shortly thereafter. First on our pilot project was a grant from New York State for 25 veterans. In the end, we saw 26, and 25 of the 26 after 3 to 6 sessions no longer met criteria for PTSD, which is not surprising to you or I, or probably a lot of people listening to this, but in the general realm of healthcare, is a pretty phenomenal thing. I think that's a 97% success rate.
So could you just stop there for a second and just, for those of us who don't know what that means, tell us what that means, that they no longer met the criteria for PTSD.
Okay, so if you get the big book of mental health stuff, the Diagnostic and Statistic Manual, the DSM, how you do a diagnosis in mental health is there is what they call criteria, which are basically descriptions.
Uh-huh.
So if you look up PTSD, they'll say, okay, as long as you meet 5 out of 7, I'm making these numbers up, and not, off the top of my head, I don't know what they are, but so one of them, you have to have, for instance, exposure to a life-threatening situation that's either, super dangerous to you, or you're observing somebody else in that situation.
Mm-hmm.
If that hasn't happened, it's not PTSD, it's something else, right? So that's the first criteria. Then there's a bunch of symptoms ones: nightmares, flashbacks, intrusive memories, change in mood, a whole series of different criteria that once you have all those things, we can officially say you have PTSD.
Okay, cool. So
we could debate whether that makes sense or not for years, but that's
right.
kind of how it is.
But as far as the diagnostic tool is concerned, that's
right.
That's how that works.
So what this is saying is, before we did treatment, they met enough of those criteria that they qualified for a PTSD diagnosis.
Mm-hmm.
After 3 to 6 sessions, they no longer had those active symptoms, so they didn't meet criteria. You couldn't say they had PTSD.
Okay.
Generally, we don't like to say cure in mental health because it's a fluid thing, but certainly at that point, and I think they did a 6-month follow-up, still, I think maybe 1 or 2 weren't in as good a spot, but the vast majority of people no longer met criteria after a 6-month follow-up.
That's phenomenal. And when, what really is impressive about that is if you compare those results to what most veterans were getting at the VA hospital up to that point, it was a night and day comparison. Like the Rand Corporation study. Go ahead.
Yeah, absolutely. You can go ahead.
I was going to say, you showed me about this Rand Corporation study where they had, 30% after extensive treatment, 30%, didn't meet criteria anymore, but they had a huge dropout rate as well. Like more people dropped out of those studies than stayed in it. So it was really kind of a skewed result. But you guys, nobody dropped out, and it was like 95% success rate. It was extraordinary.
It is a very different situation, and really because of the NLP underpinnings of all of that process that was developed. it has a lot of benefits. It's very effective. It's very comfortable when you do it compared to, say, exposure therapies for PTSD, where you have to, it's very uncomfortable.
Sure.
They work, but if we've got something better, once you learn to drive a car, you don't ride your bike a lot.
Yeah, right. Especially if you live a number of miles away. Yeah.
So I think that, it was a very good proof of concept study, which led to a second study of a higher grant, again, from New York State. This one, we had 75 participants and, again, had an over 90% success rate. There's also been multiple replications out of the San Diego office, again, always over 90%. So it's very consistently 9 out of 10 of the people involved in the study within a short period of time. Now, usually we just do 3 sessions or less. People no longer met criteria for PTSD. And I say it that way specifically because it doesn't mean their life is perfect. If you have a lifelong history of trauma, for instance, I work with a lot of people in my private practice that aren't veterans, but had child sexual trauma or physical abuse or whatever, get the same kind of results as far as the traumatic memories, but that's impacted their life in a lot of ways, that there continues to be other work.
Gotcha. So you're talking about your own private practice now, not the study itself.
Right. Yeah.
So tell me about that. So how do you use, let's say, non-traditional therapy methods in your traditional therapy? In other words, how do you incorporate NLP and some of the things that we've been talking about, like the RTM protocols, et cetera, into your therapy practice?
It's interesting because I actually was involved in NLP before I went to school for social work.
Mm-hmm.
So my frame of reference is more NLP oriented in some ways than even traditional, as opposed to, say, being trained as a psychologist or a social worker and then adding on these skills. I come at it pretty much from a Ericksonian or an NLP perspective, where it's very much about resources and being clear about outcomes and so forth. I still use a lot of traditional mental health tools. I'm always listening, and, I use different things from other parts of therapy, cognitive behavioral therapy, a lot of those.
Mm-hmm.
But I would say that in 2 ways, my kind of frame and reference and ongoing methodology is very much similar to an NLP practice would be. And I also use a lot of the specific tools. So I'll use, swish patterns and core transformation, and, reframing is just something that we all kind of do all the time anyway. I mean, that's not,
Sure.
I may occasionally use 6-step reframing or change
personal history. Let me just stop you there. So you actually will do a swish pattern in a therapy session.
Absolutely.
Really?
In fact, the one I tend to use more is Auditory Switch.
Tell me about that.
So the visual swish, the standard swish, is you switch from a cue image that is an associated image, and then by submodality changes, you go to a self-image that's also a visual representation of the you for whom this isn't a problem.
Okay.
You just switch all of that to the auditory channel. So the initial trigger is a sound, or frequently, the reason I use it a lot is voice tone.
So as an example, voice tone, if my wife talks to me in a certain tonality, then I get triggered. How dare she talk to me like that?
Absolutely. And vice versa. If you had a tone with your wife, we could use it with her.
I don't use a tone. I have no tone to my voice. What are you talking about, Bruce?
And then what you do is the self-esteem, the self-image part is then, instead of a picture of themselves, it would be them hearing what their voice would sound like if they were this person that no longer had the problem.
So the same person's voice, but with a different tonality?
No, your voice
My voice.
with the tonality you would have if your wife's tone didn't bother you anymore.
Oh, I see. Gotcha.
So in the same way, think of it in visual terms. If you're looking at yourself and you can tell by looking at them that this isn't a problem for them anymore, the way they stand, the look on their face, whatever. In the same way, and if people are very visual, I'll do an overlap and I'll have them say, okay, see yourself, and then imagine they're talking. What does that sound like? What's their tonality?
Gotcha. That's
so
great.
Then you switch from one to the other.
So ultimately, the effect is that next time my wife uses a tone like that, or I perceive it that way, let's put it that way,
right?
In case she's listening, then I would switch my response. My response
Right.
switches to seeing myself or hearing myself. In this case, since it's auditory, with a tonality saying something like, "Hey, she's just a little stressed," or something.
Right. And the subjective experience of it for the person after you've successfully done an auditory switch is frequently they don't even notice anything happen. What happens, and this happens a lot when you do NLP regularly with people in the kind of context I do, where it's not just once and that's it. I see them, whatever I need to see them. But they'll come back in a week, 2 weeks later. I'll say, I'll give you. So I had a guy that had a really rough relationship with his father. Didn't like to visit him because his father was always critical of him. I said, okay, can you hear the voice? Yeah. Does that make you feel that unresourceful in the way that you do when this happens? Yeah. We do this switch. Come back 2 weeks later. I said, hey, did you see your dad? Yeah. How'd it go? Fine. Why? It's like that's like nothing happened therapeutically, but they have a totally different response.
Yeah.
So it's one of those times where you did good work because it's kind of invisible.
Do you bring it to their attention, or just let it be at that point in time?
That really depends on the circumstances. A lot of times, to be honest, I just let it be because that's kind of a test of the work.
Right.
I may, again, if I'm seeing that person over time and that was a really big deal, then I will check it again later. But if it's a piece of work that I think that they would benefit from some insight as a client, if that fits for the case, well, then we press.
Interesting. That's very cool. Yeah, it's interesting. So let me ask you this. This podcast is called the Essential Coaching Skills Podcast. So I always like to ask my guests, if there were, in your mind, an essential skill, like if there were one essential coaching skill that you could put your finger on, would it be the switch pattern? Would it be cognitive behavioral therapy? I mean, if there was one essential coaching skill that you could put your finger on, or two, if you want to span out, you could go as far as three, I suppose. We're having a sale today. But if there were one, what would it be?
I think that is a really good question. And since I've listened to your podcast, I knew you would ask it. So what that got me thinking about was the difference between a skill and a technique.
Okay.
Because I don't think it's about, when you say essential skills, that's a different category to me than an essential technique.
Great. That's really great. Thank you. Tell me more.
And I think that there are a lot of skills within NLP that are important. And I think that the pieces that you're doing on an ongoing basis, kind of all the time and to varying degrees, would be skills. So things like, rapport and calibration and an awareness of representational systems, even the language model, meta model, Milton model,
Okay, well, I said you could have three. Now that's four, and actually five.
Okay. Well, no, wait, let me back. So, no, I was trying to give an example
of skills rather than techniques.
Yeah.
Yeah.
So I would think the core piece to me is, and I think this is true anytime two people are working together or interacting, and it's a few things bundled together, but it's the ability to have calibration skills. So you have a sense of what is going on for that person.
Mm-hmm.
right? And being able to have an outcome in mind and the flexibility to keep going until you get to the outcome you want.
Okay, great. So let me just stop you there. So I'm just jotting this down. I totally get what you're saying, and I'm going to need you to explain it, just in
No
case I
problem.
don't understand it, or somebody who's listening doesn't understand.
Well,
So calibration skills. Let's start there. What is it?
So calibration skills is really NLP lingo for sure. But basically, to make it even more kind of horribly linguistified, is a beamer, right? A behavioral manifestation of an internal response. Remember that one?
Oh no, I forgot that one. Behavioral manifestation
of an internal response. So basically,
where's that from?
That's an NLP thing from like long ago.
No way. Seriously? I don't know that one. Behavioral? Say it again.
Behavioral manifestation of an internal response.
Gosh. Okay. Tell us
basically what it's saying is when you go into a certain state, your behavior is going to indicate you're in that state.
Yeah. Yeah.
So
no, it's interesting. My partner Kevin Creedon and I used to do a class in NLP certification course where we called it the long car ride. There's an exercise we did. It's called the long car ride. And so the way it started, this particular exercise, is we would have a volunteer come up to the front of the room and think about two different people, one person that they liked to be with and one person that they didn't like to be with necessarily. And so that if they were on a long car ride with, person A, they'd be like, oh, all right, this is great. We're just hanging out and having a good time while we're driving across the country. That'd be a long car ride. The second person would be like, oh, no, I've got to be in a car with this person, right? And so we get them to have those two different people represented in their minds. And then we'd calibrate, their physiology. How did they hold their face? What kind of tension did you notice in their shoulders? How did it affect their breathing and their posture and all these different things where we would calibrate from person A to person B. And then once we did a fairly good calibration, we'd say, okay, now just shake yourself out and be in neutral place. But imagine now that you're going for a long car ride. And of these two people, the person who is taller gets into the car with you. And then, we wouldn't say anything beyond that, and the person wouldn't say a word, but we would just watch the person and notice if they, tightened up their shoulders a little bit or whatever, and just to notice from our calibration skills who just got into the car, person A or person B. So that's one way we would practice.
That's a really beautiful example and description of it. Yeah. So calibration is identifying what the sensory elements are to each of those states, whether they're with the person they like or the person they don't like. So you're doing it all visually, but that would also be true of voice tone.
Oh yeah, for sure.
And you're working in the visual channel, but they're showing it through their kinesthetics. So the ability to kind of spot.
In other words, let me just stop you there. In other words, we're seeing them, but they are manifesting it in their body. So they're kinesthetic. Right. So they're moving their body in a certain way that we can see from across the room.
Exactly. So what you ideally do at some point in your interaction with somebody is to ask them what the problem is. They will not only tell you about it, they will demonstrate it in their body posture and their tonality and all sorts of other ways that are behavioral.
Mm-hmm.
So that's a beamer.
Okay. Good. A behavioral manifestation of an internal response.
And then when you ask them about what the desired state is, their goal, where they want to get to, they're also going to demonstrate the state that they want to be in.
Oh, nice.
As you ask them about it, as you elicit that, what's that going to be like? Questions like that. So now, as you're trying different things, whether it's a simple conversation or giving somebody advice or some elaborate intervention, in the end, when you offer them the opportunity to respond to the original context, future pacing would be a way to say it, right? What you want to see is that they automatically show the desired state.
Yeah, that's so great. This is, Bruce, why I wanted you on this show. No, seriously, because you have a way of getting to the crux of the matter. I mean, for me, that's the crux of the matter.
Right.
When people talk about stuff, they can be lying to themselves. They can be fooling themselves, but the body doesn't lie. So if you're watching, if you're watching them and calibrating appropriately, you see that, they're shrugging their shoulders like that, or their face is screwed up like that, or whatever. And then later on, if you want to test your work and see if they've gotten any change, go like, yeah, I'm feeling much better, and they're shrugging their shoulders and screwing up their face.
Right.
It's like they're not feeling much better. So you got more work to do.
Right. I mean, let's see, how can I do this without getting sued? So I was listening to a podcast.
Always a good question to ask.
Right. Oh, it's always right there. Let me check with my attorney. So I was listening to a podcast by a very, very well-known within the realm of psychology, Ptsd psychologist who's written many books, very top-of-the-line guy. And he was having an after interview, like a week or 2 weeks later, with somebody that he had claimed to have resolved PTSD with, and did a follow-up a few weeks later, right? And as I'm listening to it, I can hear in the guy's voice that he's becoming completely overwhelmed just talking about the treatment related to it. Now, I'm not saying he didn't benefit,
Mm-hmm.
right? I think he did. He talked about ways that he had benefited. But at the core level, the piece that the movie theater technique, RTM, is really good at did not get taken care of.
Right.
The beautiful thing about that kind of work, or, you do havening, similar kind of intervention in a way,
Mm-hmm.
as far as how the change occurs, in my opinion, those kinds of things, when they work, it because you try to trigger the person and they won't.
Right.
It's not a conscious process.
Button and nothing happens.
That's right. It's like you can't keep people from pushing your button, but you can unhook the wire.
Exactly. Yeah. That should be a bumper sticker. Say it again. You can't. What'd you say?
You can't stop people from pushing your button, but you can unhook the wire.
Did you say the people before, first time?
Can't stop people, maybe. Yeah.
I thought you said the fool. I thought you can't stop the fool from pushing the button. But
I like that better. We'll go with that one.
But you can unhook the
wire. You can't
wire.
stop the fool from pushing the button, but you can unhook the wire.
I like it. Yeah. Well, and that's, exactly. And again.
Okay. So circle back real quick. So that calibration, flexibility, knowing where you're going kind of triad.
Right.
If you think about it in another context, teaching, for me, people that are good teachers do this, without even knowing it. But basically, they teach you something, and if the little light in your eyes doesn't go on, if they can't see an outward manifestation of the aha,
mm-hmm.
then they change their tack and they teach you in a different way. They use a metaphor instead of writing it out on the board. Or what really good teachers know how to teach the same content multiple ways, and they just keep going until blink, and then they move on.
Yeah, exactly. No, that's
bad teachers just have one way.
Yeah, bad teachers just kind of read the material and say, "Okay, I've done my job. Time to go home. See you next week." Yeah, I got that. It's interesting. My one of my teachers, Dave Dobson, used to call that the nickel drop experience. It was showing his age for sure, but I knew what he meant, which showed my age for sure, because because in the old days, long time ago, you put money in a payphone.
I thought you were talking about a nickel bag.
What's that?
I thought you were talking about a nickel bag.
Oh, no. Well, that's not just showing your age; it's showing a culture, lifestyle. Nickel bags
mostly legal
around here, but anyway. Right. So, what was I saying? Yeah, so in the old days, in my old days, you put a dime in a payphone, but some phones were designed, and I guess Dave's were designed so that you'd pick up the receiver, you'd get the dial tone, you'd dial the number, and then when the person answered, there'd be no real connection. They'd be going, hello, 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 but it wasn't. Then you would put the dime in, and then when the dime dropped down, go cha-ching, then get like, hey, Bob, how you doing? And there'd be a connection. You actually got through.
Right.
So Dave called that the nickel drop. So when you're teaching the concept in a class and the person just looking at you with like a deer in the headlights, they're not done yet. They ain't got it. You don't got that connection. But if you explain it a different way or do a metaphor or just say it again, and then they go, oh, right, got it. You get that full body nod, where they're saying yes and their body's nodding, their head's nodding. Then you got it. You got the nickel drop. So, yeah.
Absolutely. Yeah, I think that's a huge part of how so many things work, but especially, any kind of coaching, treatment, stuff like that.
Yeah. And it is also really true that, it's traditional therapy. I mean, if you think back to Freud, et cetera, Freud would be sitting to the side of the person, maybe facing away from the person, while the person
Right.
was lying back on the sofa and recounting their dreams or whatever. And Freud wouldn't even be looking at him, just reading, writing in his notebook or whatever.
Right. Well, that was the tabula rasa thing. The idea that you didn't want to interject yourself on the client at all.
Sure, I understand.
And that was the thing I used to get into arguments in grad school about all the time. That they'd be like, you can't influence your client, and I'd be like, you can't not influence them. I mean, that's nonsense. You got to own it.
There you go.
That's the key. You gotta use it ethically. If you don't own it, it's like having a gun with no sights on it.
Wow, very cool. You're full of good metaphors. Yeah, that's that's really true. In NLP, we've often said, you cannot not communicate. You cannot not anchor. Right? Yeah, and this is true. You cannot not influence. Same idea. So the tabula rasa.
Once they've decided to call you up, you've already got power.
Right.
And it's not that you want power, you have it because they've decided that for some reason they need to talk to you.
Yeah.
Well, now you have to figure out what to do with that.
Right. Exactly. Yeah. Yeah. Now, it's also true, of course, that it's really good to be aware of the transference and countertransferences things that happen in sessions, and that power thing is one of them. He's the therapist, he's the guy or she's the guy,
right?
Sort of thing. So they're looking up to you in a certain way, and you want to break that apart in some ways or not, depending on the situation. But being aware of it, and also being aware of that, the countertransfers. How the therapist thinks about the patient, rather.
Absolutely.
So those are really good things, I think, are emphasized a lot in things like social work and traditional therapy that sometimes don't get talked about as much in a NLP or other situations.
No, it's just a different. I think NLP is wonderful stuff. I think it's it's helped me immeasurably just in life to view things in different ways. I think Bandler and Grinder were really good at collecting stuff. They're kind of like Steve Jobs was good at stealing, other people's technology in a way. Like the Mac was something that was developed really by Xerox, but he saw it and was like, wow, that's important. And not that he didn't have his own creativity and his own brilliance, but one of his talents was seeing something good. And Bandler and Grinder did that with whether it was identifying patterns from Pearl, Satir, and Erickson, or lots of other ideas at the time. I think they were very smart. Totes, all that stuff. They were able to see the value in.
Right.
And I think that having that good eye is important. There's good stuff in everything. I'm really frustrated. The one thing that I was frustrated with Erickson, and that's kind of in the DNA of NLP, is trashing other schools, trashing psychology. NLP is a wonderful thing to add to almost anything. I wish more clinicians were still involved in it, because I think it is the nuts for a therapist to know these tools and this way of viewing the world. But it's, it informs everything I do, but it's not all that I do.
That's a really great point, and I appreciate that. I do have a question about that, and it is this: in NLP and hypnosis, a lot. I see people twice, three times. Havening too. People come in for a phobia or a trauma. Two, three times, done. Not always, but a lot. A lot of times, it's a very short-term, solution-oriented therapy. You see people for a long time. I mean, you see people once a week for ages and ages and ages, years and years, and lifetimes, really, lifetimes over many lifetimes.
I don't think that that's a really good representation of my practice.
But seriously though, you do have an ongoing practice. People do have a regular set appointment.
It depends on. Okay, so I have a variety. If in case this goes on to YouTube, I'm currently in my basement in a small town in Western New York because of the pandemic.
Because of the pandemic. Well, if you saw what was behind the screen here, you wouldn't feel so bad.
Yeah. I'm wishing I had a screen or a Star Wars sheet, something.
Yeah.
So in a rural setting, so I'm in a county with no cities in it, right?
Mm-hmm.
I have a very generalized practice. So I see people with lots and lots of different presenting problems. The county above me is Monroe, which is where Rochester is. I regularly have several psychologists up there that will be working with a client and they have some trauma, for instance, is a common one. They send them down to me. I see that client for a couple of sessions, do the trauma work with them, do that piece, and then they go back to their primary therapist. So some people I'll see once, three times. On the far end of the spectrum, I have some people that have some significant mental health issues that are not, in my opinion at least, something that can be handled in a few sessions.
Mm-hmm.
And I do see them ongoing for a long period of time, some years. Most of the people I see probably are in the 6 to 10 sessions.
Okay.
So I will see them over a period of time. But I think that, I don't think most practices would look that are dealing with mental health, right? A lot of the people that are demonstrating NLP are trainers. They don't have a practice.
Mm-hmm.
And the difference between doing a demonstration of a specific technique on somebody that is functioning well enough to be able to afford NLP training is going to be different than some of the people I see in my practice.
No, that's very true. Very true. In fact,
I think they're different populations.
Your practice is actually some people who are referred to you, sort of thing, as needing mental health.
Virtually all of them. I mean, my primary referral source is doctors.
Okay, got it.
So I mean, most of my people are on medications and have lots of other pieces going. Now, some of them are there miraculous NLP cures, that go like that. Absolutely. If somebody wants to Google me for an article I wrote for the Psychological Networker a while ago, there's a really neat article in there about a kid that I saw where we did some work on a voice that was bothering him.
Mm-hmm.
And although I had seen him for more than one session, that piece is what really did it for him. So
yeah,
it happened.
Yeah. It's interesting. My own training as an NLP trainer and also a hypnosis trainer, I have instituted in my trainings now actually a requirement that before people get certified, that they have to work outside of the class with, at least 5 different people. It's a small hurdle to get over for somebody to get certified, but to work with 5 different people who are not in the certification training and they're not co-students. They're somebody who wants real help and don't even know what NLP stands for or what hypnosis really is, sort of thing. And it is amazing, truly, I think, how much a person learns when you start working with people like that. because
yeah.
they don't know, what NLP is. They don't know what an outcome is. They just are in pain and want to get out of pain, basically.
Right.
Putting it in a nutshell. So then
Yeah.
then you
When
really
you go, any part of you object to this? Oddly enough, people on the street find that a weird question.
yeah. And how are you representing that belief to yourself in your mind?
Exactly. So tell me about the image. What image?
Yeah.
How do
Where
you
are you
know
seeing
that?
it?
I thought it. It's a different. They don't know the rules.
Yeah, they don't know the rules. So it's really, really instructive to work with someone and people. So I have had a private practice for 30 years, and do training. So I know exactly what you're talking about. And again, one of the reasons I wanted you on this broadcast is because you also have been in a lot of trainings, done trainings. I've met you in a training, met you in one of my trainings. I think you came to one of the trainings. And that you taught me basically the particular RTM procedures that you, I'm sure, had helped create with Steve Andreas and others for the R&R. When I helped out with the research and
And in
recognition
that case,
project.
it was you're doing a study. You have to follow a protocol
Have
a
to
lot
follow,
more
yeah,
closely.
right.
We did build some flexibility into it, but that's a situation where it's totally opposite of what I said the essential skill was.
Right.
To do a scientific study really by the book, you do use a manual in effect, and you say, okay, this is what I say to you, and you try to systemize it.
Yeah. And of course, you have to do it that way. Otherwise, you're not getting good results about what happened in the study. It was one of the challenges, by the way, when I was working with Dr. Oz at the Columbia Presbyterian Medical Center, because we were supposed to be there doing a study on did hypnosis work in a medical situation. But it was very hard to do, a faux hypnosis, for the placebo effect. How do you do fake hypnosis where they think they're getting hypnosis, but they're not really? It's like, it's by definition impossible to do.
Yeah, well, we ended up doing, because at one point we were going to have to do a design that had a control like that.
Mm-hmm.
We used a waitlist design, so we didn't have to do it. But a better, more rigorous study would have been to have 3 groups. And the control was going to be taught how to do progressive relaxation.
Okay.
So that would be it's still a bit of a treatment, but it's not, I think it would not have been anywhere near as effective as the movie theater technique.
No, not at all. I mean, I'm guessing it wouldn't have been. I'm certain it wouldn't have been, honestly.
Right. Oddly enough, it would have been effective with some people.
Of course, everything's effective.
How it always goes.
And just simply being in a therapist's office and talking about your stuff, occasionally is therapeutic for some people.
Yep. Takes us back to that same idea that once there's a great study Michelle Weiner Davis did 1 million years ago. I don't know if you've ever run across her stuff. She did a book with Bill O'Hanlon.
Mm-hmm. Yeah, I know her stuff.
And she has a whole business around divorce busting.
Yep.
And her study was, they just started asking people when they came in after they booked an appointment at the first session, what's been better or different in the week since you booked your appointment. And people would identify things. Just having made that call made their life better.
Huh.
So you would start that. It was a solution focused study. So you would start that finding the exceptions even earlier. And I'm not as religious about it as I once was, but for years I would always do that. I'm just curious. A lot of people report that things get better after they make the phone call. What's been better since we talked the other day? Well, it's funny you mentioned that.
Huh.
It starts to shift their mind.
Yeah.
I think that the other thing that gets lost in NLP sometimes is this is a nudger's game. It's not a sledgehammer.
I'm sorry. You're going to have to expound on this metaphor that you came up with, Mr. Metaphor. This is a nudger's game, not a sledgehammer?
Yeah, you nudge your clients in the right direction.
Uh-huh.
It's about being a nudge. It's not, sometimes you get to come in and go, hey, you had a trauma, I can fix this. And it's great. But most of the time you're kind of nudging them in the right direction. It's a lot like Erickson's story of the horse, where he finds a horse as a kid. Yep. And he didn't know what farm it was from, but by just kind of keeping it on the road, the horse knew where he was going eventually. It's very much like that.
Cool. Yeah, it's a great story. Great story by Erickson. Yeah, very nice. Yeah, it's a nudger's game, not a sledgehammer. Yeah. So many opportunities for bumper stickers from this, Bruce. It's really...
I, I try to have memorable statements.
You're doing very, very well.
Thank
we should also talk about getting a screen for the next time we do one of these calls, or else,
or at least a giant hat.
Giant hat. That would be
I could be
really good.
in a sombrero, but then I'll get busted for cultural whatever that's called.
Yes. Hey, let me ask you a question. Since we've brought up humor, or one of us has, I'm not sure. Do you use humor in your therapy sessions with?
I do, and as even though it was a long, long time ago, I'm still milking the fact that I was a stand-up comic in my first career. I think humor is hugely important. Obviously, if you're not a funny person, that's okay. But if you have a knack for humor at all, I think it's a great way to make points. I think it's a great way to build rapport. And I think, most humor is really one form of reframe or another.
Yeah.
So there's also, I read an interesting study years ago where they were doing split vision testing. And so what they would do is they'd put a pair of glasses on somebody. One side would have vertical lines, the other would have horizontal. And then they'd say, okay, do you see horizontal? They're seeing which eye is dominant, right?
Mm-hmm.
And in the middle, a guy came in and did something funny or told a joke. I can't remember what it was, but the person laughed after they put the glasses on, but before they got asked the question. And somebody said, do you see vertical or horizontal? And the person said both. And it led to a whole different line of study, which showed that after you laugh, both hemispheres of your brain light up.
Wow.
It increases the communication. And when I heard that, I went, like almost every therapist that's like a famous therapist uses humor.
That's true.
If you watch the videotapes, whether it's, Albert Ellis or Erickson used really kind of weird puns and funny stories. Yeah. Bandler and Grinder heavily relied on humor. It's a very common thing. Even, if you watch, a lot of those people from the 70s and 80s.
Well, Frank Fairley is famous for his humor.
Yeah, Frank Fairley, great example. Dobson used humor.
Yeah.
And I think it helps to light up the circuits.
Yeah. Well, if you can laugh at it, then you've got it rather than it having you.
I think it's also dissociative, right? I think that to laugh at yourself, you have to dissociate. If you imagine slipping on the ice, that's a very different experience than imagining yourself slipping.
Oh, yeah, very true. Yeah, beautiful. Well, gosh, Bruce, so delightful talking to you. It's really
it's that's fun.
Did you say like it wasn't so great for you?
It's the damn internet. No, I said it's the best time I've ever had.
Hey, I'm calibrating your physiology right now, Buster. There you go. Now I believe you.
That's right. No, it's been great fun.
Really, it's you've brought up a lot of really good things to think about. I love it.
Hey, you want my one tip for how you make money?
What's that?
Know your referral sources.
What do you mean by that?
Figure out who are the people that are going to send you people. Word of mouth, all that stuff's great. I have lots of clients that come to see me because their friends saw me years ago or whatever. But my main source of referrals is medical doctors. So I do things to encourage that relationship, whether it's making sure I send them letters or whatever. But the point is, that's not what's going to work for a coach. They have to figure it out. So if they're an athletic coach, they better start glad handing athletic directors at universities or something. I don't know, whatever it is. Mm-hmm. But you have to be aware of where your referrals are coming from. If it's from your website, then you should be spending a lot of time making sure your website's working for you. Whatever it is can be different, but you have to know what yours is.
Well, let me ask you a quick question about that then. So you said writing letters to physicians or to doctors?
Mm-hmm. So anybody who comes to see me, whether it was their doctor specifically or not that referred them to me. And this normally, you're supposed to do this if you most of my folks use insurance, right? But a lot of therapists don't do this. I don't know why. I send that doctor within a couple of days the complete assessment that I did, and I say thanks for the referral, whether it was them or not, but I make sure they get communication. If I'm having trouble with that client or for any reason, I've got to either call or do a letter to that doctor, I'm going to do it. Because that's the relationship that feeds my practice. It's also good care, so it's easy, but.
So you're not just talking about sending a thank you note or something like that. You're sending them the actual.
In this case, no, but I would do that also if that's what was appropriate. Okay. But I keep the communication going. In that case, we're both cooperatively treating that patient, so it's appropriate for me to be talking with them on an ongoing basis of how to do that. But it's the relationship piece as far as the referral goes, it's important. So if you've got a certain class of people, I'm saying doctors, but it could be athletic coaches or it could be business people or whatever, even therapists. If you do havening, you could build relationships with therapists that would do like I do, send you somebody for a few sessions and then you send them back. But it's the relationship that makes it work.
And do you have a letter that you send out to people to say, hey, my name is Bruce, I do this kind of therapy, if you have anybody?
I have. I depends on the situation. Sometimes I'll do letters like that. Sometimes I'll call somebody up. Any opportunity to get the information out or to introduce myself. As a new doctor comes to town, I mean, I'm well established now, so I don't really have to do this stuff, but I used to. If I was aware that there was a new doctor to practice, I would try to set up an opportunity to meet with them, introduce myself.
Cool. Great. Yeah. Thank you. Yeah, that is important. And I apologize for not asking that question because that is part of what this Essential Coaching Skills podcast is about, is how do we not only take our practice, where we're helping people, how do we help people better, but also how do we, elevate our own practices to become better at surviving.
Yeah.
And
no point being skilled if you don't use them.
Yeah, that's great. So once again,
my pleasure. Thanks very much.
Well, that's our show for today. Thank you so much for joining me. If you want any more information about today's show, please visit our website at www.essentialcoachingskills.com. Be sure to tune in again next week for our next episode and discover even more about the systems and the secrets that set the best apart.